This is Intention to Treat from the New England Journal of Medicine. I'm Rachel Gottbaum. We're now joined by Dr. Cornelia Griggs. She's a pediatric trauma surgeon and education director of the Center for Gun Violence Prevention at Massachusetts General Hospital, and also David Reedman. He's a data scientist and founder of the K-12 school shooting database. David Reedman, I'd like to start with you. You were working as a consultant for Homeland Security and then began doing research into school shootings. Why?
I was at the Naval Postgraduate School in 2018, working on a Homeland Security think tank project. And in the midst of that program, thinking about the future threats to our country, the Parkland shooting happened. My background was working on terrorism and intelligence investigations. And we have very clear checklists and procedures for how to identify somebody that may be going down the road to commit a terrorist attack. And it seemed like a similar framework could easily be applied to preventing school shootings. And that's when I realized that there was no information about school shootings. And that took me down the path of gathering as much data as possible. There have been more than 2,400 different shootings at schools back to 1966. It is now an American issue.
Dr. Cornelia Griggs, I'd like to turn to you now. You have lived experience with this in your day-to-day clinical work. Tell us how you got into gun violence prevention research.
I'm a pediatric surgeon, and I got sick of taking care of kids who were getting injured by bullet wounds and began to feel that as a physician and as a parent and a human, I had an obligation to work on prevention, not just treating traumatic injuries. Then I wrote an op-ed with my partner, Peter Masiakos, and I told the story of how heartbreaking it is to look a mother in the eye and tell her that we did everything, but we could not save the life of her child, who was unnecessarily killed by gun violence. And that struck a really strong chord with the medical community that felt really helpless as a collective. When we first started talking about doing gun violence prevention research at MGH, there were very few government-funded grants that even acknowledged gun violence as a public health issue. And I think normalizing this conversation in the context of healthcare was a big paradigm shift, because when we know that something is the number one killer of children in the United States, we need to activate the healthcare community.
David Reedman, can you explain the Dickey Amendment that essentially banned federal funding of gun prevention research because it would impact gun sales?
In 1996, the Dickey Amendment essentially prevented the CDC from using any of its funding for anything that related to gun violence research. We never built the research institutions that would be studying all of the aspects of this problem, from systemic gun violence to suicides to intimate partner violence to mass shootings in schools. There would be research institutions that would have carved out niches and would be gathering this information. But in this one, the lack of information is so stark that we end up making public policy decisions based on assumptions rather than data. So thinking about this process of uncovering these shootings, last March, I saw a Google alert for somebody killed at a school. And there was very little information, but in the picture on the article, there was a picture of the coroner's van. So I knew that something had happened at this small middle school in rural Indiana. I finally found a community message board, and there were people talking about how this person was their favorite teacher. They can't believe this would happen. I couldn't find any other information. So on Monday morning, I called, and the woman at the front desk told me that a 7th grade teacher had killed himself in front of the class. So a suicide by a teacher with a firearm in front of a class would never be reported anywhere in the same state and the same region that is talking about arming teachers. So without data, we make very poor public health decisions and public policy decisions. But when you look at these cases in aggregate, you see patterns and we can develop interventions. And that's what the medical community has done successfully for just about every other problem.
So you were saying that we're making policy decisions without data. Let's talk about what you've seen on the evolution of these school active shooting drills.
I didn't start this project until 2018. And in 2018, there was no empirical evidence on the characteristics of shootings in schools. There was no good data available to analyze anything. Yet, 20 years before Parkland, in 1999, when Columbine happened, it spurred a school security industry and it spurred the early lockdown procedures in schools. There was never a peer-reviewed study to find out if this is the best action to take. School shooting drills have really been built around a narrative, an image, a fantasy of this deranged outsider coming into the school and determined to get into every classroom. And in each classroom, they're going to kill as many people as possible in the room. And that was really built out of Sandy Hook. And Sandy Hook was this incredibly tragic shooting, but it was a very uncommon circumstance. And in every single public space, whether it's a shooting or a fire or a gas leak or a train crash, we tell people, get away by every means possible. But somehow, without any evidence behind it, students are being told, sit quietly in your classroom, even though danger is here, even though somebody is coming here specifically for you. And that decision has never been based on any evidence. Overwhelmingly, across 60 years of school shootings, they are almost all committed by a current or former student at that school who knows the plan, knows where students are going to go, knows the layout of the building, when the shooter knows the drill and knows where the students are going to be. You can have a situation like Uvalde. Somebody who's familiar with the school can plan an attack, and they know that when the first shot is fired, this is exactly what everyone will do. And if they get into one classroom, all of those students will be waiting there. And in Uvalde, that was tragic, because if those students had run, some of them may have been killed, but it would not have been as bad as it would be staying in the classroom for more than 70 minutes watching your classmates bleed out.
So Cornelia Griggs, you're focusing on the schools now. Tell us what you're trying to do and what you're finding out about these active shooter drills in schools.
We started with trainings to equip clinicians with language to talk to their patients about firearm safety and safe storage and gun violence prevention more generally. And when we started to think about how we could get that kind of curriculum into schools, we immediately jumped to the idea of working with school nurses. And nurses are telling us that they are walking away from situations where there are hyper-realistic active shooter drills, and they themselves are traumatized by the experience. And they are watching the children be traumatized by the experience. They are telling us that they see preschool-age children go home and tell their parents that there was a shooter at school today. And they are telling us in some situations that they feel a gun violence incident at their school, if it hasn't already happened yet, feels inevitable. And there is a lot of concern about the long-term and harmful psychological effects of hyper-realistic active shooter drills, and that they are in many instances likely to be much more harmful in the long term than helpful in any kind of realistic scenario. And I think we need to understand what works before we widely implement something without understanding the long-term consequences.
So, David Riedman, do you think we should have these drills? How prevalent are they? And what do you see that's needed?
One of the first things to do with any school security plan is look at prior incidents and say, how many times would this have been helpful? So last year, there were 305 different shootings at a school. 2 of them were deliberate attacks. The other 303 were a time when a gun was fired. And in that moment, students hear gunshots, teachers hear gunshots, the school goes into lockdown, usually for hours, for 3, 4, 5, 6 hours. And because everyone heard that gunshot, they think that it is the real thing. They're texting their parents, I love you, goodbye. But in reality, what we can see from data is that the most common situation to happen at a school is a fight that escalates. There are more teenagers carrying weapons than there have been at previous points in history. And when there's a conflict, these conflicts are turning into shootings. And the shooter almost always runs immediately. So there's no threat at the school anymore. But we only have one plan for when a shot is fired, and that's lockdown. On the other end, when there is a deliberate attack, there have been 230 of those since 1966. They don't all happen in the classroom. But because Sandy Hook was a shooting in the classroom, everybody gravitated towards every shooting being a shooting in the classroom. And so we've created a plan around one scenario. In fact, we have a much more complex landscape of different scenarios. And if you look at each one in detail, getting away from the school, getting as many people away from the school as fast as possible is almost always the best thing that you can do.
So, Cornelia Griggs, what's wrong with this lockdown mentality or what David Reedman is saying?
The nurses that we spoke to as part of my research expressed over and over again that there is a mental health crisis unfolding for young people and that we are ignoring the fundamental drivers of gun violence. And when there is a gun violence incident in a school, that what these children want and what they need is their community, and they need to feel held and supported by their community. And when you put something in place in schools that feels perfunctory and ineffectual, you are likely causing more damage for the people who are going to school in that building or working in that building than you are alleviating any sense of fear.
So what are you trying to do in these schools?
The nurses that we have surveyed, what we have learned is that gun violence is at the top of their minds in terms of being a concern for their students and their daily lives in school. And the goal of our work is to train them to feel empowered to have these conversations in schools, to talk to parents, families, and students about firearm safety counseling, safe storage, gun violence prevention in the community, that we can change the conversation and we can take them from a place of feeling like sitting ducks who are showing up to school every day, just waiting for an active shooter to enter their school. And school nurses are the perfect people to deliver this message for students and families because they are trusted members of the community and they're a friendly face that the students see every day that they come to when they are hurt and injured. And they're often the first call to parents when a child is suffering from any kind of ailment, whether it's a headache or whether it's coming to the school nurse because they are afraid that they have a family member who is depressed and dangerous and has access to a loaded weapon. Or there's a very young child who shows up in the nurse's office for an otherwise common complaint and is sharing a picture of themselves holding a loaded weapon. There are some schools where that has become a matter of routine, children showing up with pictures of themselves holding a loaded gun.
Can you speak to how you're trying to change culture by bringing this out into the open?
Decades ago, it was taboo to talk about your sexual orientation. It was taboo to talk about alcoholism or drugs. And the cultural narrative around a lot of those topics has changed dramatically. We need to normalize having conversations about safe firearm storage in any number of clinical scenarios, whether it's an OB visit, whether it's a regular well child visit in pediatrics, whether you are taking care of an elderly person with dementia. It is not part of our routine to ask about access to a loaded weapon, but we are asking them about how many fruits and vegetables they're eating, and we're ignoring the number one killer of children. And the more we normalize that conversation in a healthcare setting, the more we can start to have common sense solutions to gun violence in the United States.
David Riedman, where do you see some of the solutions here?
The way that we're going to find solutions to this problem is through empirical evidence and basing public policy on data, not on assumptions. The school security industry has been built around ideas of what might happen. We have never looked in depth for the root causes of this problem, the downstream solutions, and whether the things that are being done are helpful or harmful. And until we take a close look at this issue to ask, are we doing the best thing for the kids in this classroom? And if people aren't sure that that answer is yes, then we need to find a better solution for them.
Thank you both so very much.